some of you have had this too, is I've had people apologize to me for not remembering, for not being able to, oh, I'm going kind of crazy here. Sorry about that. People apologizing for not being able to remember or being able to really focus and concentrate. Has anybody had people? Yeah, so, we know that this exists, and I want to share with you, so in the textbook that we've currently done, our beloved, cherished, brilliant Joletta Belton writes chapter 1, The Lived Experience, and it's a beautiful chapter, and I want to share with you what she writes in there on this topic. She says, extending kindness to oneself can be difficult for people in pain at a time when feelings of shame, guilt, anger, grief, sadness, despair, purposelessness, hopelessness, and worthlessness might be prevalent. We may not feel like ourselves anymore, and we may perhaps not like who we've become very much. And this is further to her quote, I was quite angry and upset with myself for a long time, beating myself up constantly for not being able to figure it out, for not doing this pain thing right, for not getting better when I was supposed to. I beat myself up for being in pain at all, for not handling it better, handling like I should have. It took a long time and a lot of practice to begin to be kind and compassionate with myself, to see that I'm just human, trying to figure it all out like everybody else is, having very human experiences of which pain and suffering were a part. I'm more kind and compassionate with myself now. And she does go on to say that mindfulness, meditation helped her. It helped her be less reactive. It helped her be more accepting of the moment, and at the same time, still staying really curious and open to possibilities, which included a new narrative, and then that led to a change in her pain experience. So thank you for sharing that, Joletta. That was very powerful, and I hope lots of people are exposed to your experience. So research shows that emotional and psychological health can be influenced when pain persists. So we know this. People in pain, the research has showed, have a tendency to have anger towards themselves, towards others, frustration, self-blame, criticism, shame, anxiety, and fear. And I said all that because the self-compassion research shows that it counteracts some of these tendencies. So there may be something to this self-compassion thing. So people with high levels of compassion and compassion-focused training in some cases show reduced, I'm not going to say all that, but there you go, reduced all of those things. And then also increased motivation, life satisfaction, even emotional resiliency, adaptive coping strategies, better able to cope with failure, and health promotion behaviors. Now I want to stop here for a moment and talk about motivation. So Kristen Neff talks about this a lot, and I find this fascinating, and I hope it speaks to a lot of you. So when we look at self-compassion or self-kindness versus self-criticism, sometimes there's this belief that self-compassion or self-kindness might be too soft. It might be like an excuse and get us off the hook, so then we can't really change our behavior. And so the self-critical voice may be better, So you think of something maybe recently that you're not proud of. I had one this morning. So you said something maybe you didn't want to say, or did something, or vice versa. Maybe you didn't say it and you should have. So can you think of a moment maybe recently or in the past? So you can respond to that in two ways. So the self-critical voice would be like, oh, seriously, come on, Shelly. Like, you have a better head on your shoulders than that. That's not too bright. What were you thinking? Come on, you're supposed to be a decent human being. That was rude, okay? Or the self-compassion voice. Kindness, okay, I did my best. I was in this moment. I know I probably could have chosen a healthier response, but I did the best in that moment. I'm not alone. You go through that self-compassion component, the mindfulness, the kindness, the common humanity, and you just sort of give yourself what you need. So what the research is saying is that the self-kindness voice, or the self-compassionate voice, is actually more associated with behavior change, believe it or not. Now, self-criticism can change behavior as well, but it's found to be maybe not as sustainable, and self-criticism is more associated with anxiety and depression. Whereas the motivation to change that comes from the self-compassionate voice is rooted in love and a real, genuine concern to alleviate the suffering or unpleasantness that you're going through. Does that make sense? And I'm really excited about that part because that really spoke to me because of my self-critical tendencies. And so that when I learned that and I started practicing that just a few years ago, it really helped me. So now I just want to go through these 5 studies. This is now self-compassion in the context of pain. So there are 5 whopping studies out there with self-compassion in people in pain, which I think is exciting, and I'm sure there will be more. So I'm not going to spend too much time, but I do want to share them. So Wren et al. 2012, self-compassion in patients with persistent musculoskeletal pain. So this was a study of 88 people, and the people that had higher levels of self-compassion showed these: reduced pain, catastrophization, levels of disability, and reduced negative affect, and increased pain, self-efficacy, and positive affect. Another study, Purdy-Morley, 2015. This was 60 patients with persistent pain. This was a vignette study, so they had scenarios, and they were self-reporting and imagining what their response would be. So people with higher levels of self-compassion here, which they measured using the self-compassion scale that Neff created in 2003. So these were the results here: reduced negative affect, avoidance, catastrophization, and rumination. And then Costa et al. 2011, this one was 103 participants, again with persistent pain, and this study showed reduced depression, anxiety, physiological responses to stress were reduced, and increased pain acceptance. And just to take a moment here to talk about pain acceptance, we have a large body of research, as some of you may know, most of you may know, that supports the value of pain acceptance in people in pain. And this idea that pain acceptance is associated with reduced depression, anxiety, even physical and psychological disability, and associated with increased quality of life in people with low back pain, as well as reduced behavioral avoidance. And this comes from a lot from the ACT research, acceptance and commitment therapy, with McCracken and Voll's work. And then the last 2 studies, now these are the only 2 studies that I could find that I think are out there, on self-compassion as a therapeutic intervention for people in pain. So now these people are actually doing these compassion-focused therapies or training. So Chapman et al. 2013, this was a small study, 12 patients, over 9 weeks. They went through this compassion cultivation training. It was a Stanford program, and these were the results from that study. And then the other one, the last one here, Carson et al. 2005. This is where they did the loving kindness meditation, which we experienced for people with persistent low back pain. A pilot study here, and these were the results from that. That was in, did I say 8-week? And this was 43 people with persistent low back pain. So we don't know the mechanisms underlying the effects of these compassion trainings for people in pain, but growing research does suggest that it may activate the brain regions responsible for engaging the endogenous opioid system and activating positive affect through upregulation of our social affiliation system and not downregulating the negative affect, which that is the mechanism that's believed to be what's happening when we're during cognitive reappraisal, during emotional regulation practices. So I thought that was interesting, that this is different, and that might be relevant, for us. It expands our options, and here, this is something different going on. Of course, like anything, more rigorous research is needed to show that self-compassion training is really appropriate and effective. And we don't know if there's any adverse side effects. It seems like there wouldn't be, but there is some interesting things that I've read over the years. Just in writing my chapter, I really came across some interesting, they're not really adverse effects, but just fears, blocks, and resistances. So some fears that we can have to compassion, and I'll be talking about that in a moment. Okay, so self-compassion in the healthcare provider. So this is the last orientation. So this is the benefits here. It can really be some of what we talked about, like in the general population, just a few slides ago. So the improved health outcomes, the physical, psychological, emotional well-being, emotional resiliency, but increased concern for others. So we don't have the research that shows if we practice cultivating compassion for others, that it translates and we're more compassionate to ourselves. We don't have that yet, which I think is interesting. But we do have, it shows that if we can cultivate self-compassion, that it seems to translate that we might be a little bit kinder to others. So I think that's interesting. And of course, concern for others, that's something that we're interested in our profession. And of course, again, the reduced burnout and empathic distress fatigue. So the compassion, it's a good thing, right? Do you agree? If you have any questions after, though, please still feel free to challenge me on that. But it seems like it's a good thing, yet we do have fears, blocks, and resistances to compassion. So I find this fascinating because I think I'm a pretty decent human being. I try to be kind, but I have times when I am not. And I'm sure we can all admit in here there are times when we didn't act as kind as we wanted to. Why is that? Like why? And there are some things. And there's, by the way, there's an entire chapter in that Oxford Handbook of Compassion Science on fears, blocks, and resistances. So again, if you're inspired and you find it fascinating, pick up that book. Okay, so one block may be unmanaged personal distress. Maxie already talked about this. This is our own system. If we are dysregulated, if we are in a state of dysregulation, we are not, or neurophysiologically, we are not in that capacity to give, to offer. It's just the way we're wired. Does that make sense? So there are things that we can do to regulate ourselves, and therefore that may help us prime for compassion. Also, we may be overwhelmed by the stories that the people are telling us. And the research shows, this isn't in healthcare setting in particular, but it shows that we're more likely to be compassionate and provide a compassionate response if there's like one person. And then as the numbers go up, the compassion goes down. So, we can kind of translate that. It's conjecture, but we can translate that to the problems that we're hearing. We may feel like we can't do it, we can't help, and then we shut down, again, going into that dorsal vagal neural platform where we go into shutdown because we can't do it. And then we may have the belief that compassion might be unhelpful for this person. That could be based on our beliefs, our belief system. Remember how I talked about the motivation and versus the self-criticism? So maybe we believe inherently that compassion is this soft skill, and it's not going to be the best for that person. They need the iron fist, they need the kick, they need and maybe we feel that in order for us to best help them, we want to have them, that the self-compassion might get them, too dependent on us and all that. So beliefs can be there in the way. And then I think this one speaks to a lot of us in the healthcare profession, which is the fear of the cost of caring. So if that's the idea that if we just keep giving, we have limited resources, and if we keep giving and giving and giving, we're going to have nothing left to give. Of course, we can't put all the blame on the healthcare provider. There's organizational barriers, shortage of time with people, long work hours, the environment, the culture may not be conducive to compassion. There may be a belief there that, compassion is unprofessional, or even just your colleagues maybe ridicule certain things. So there's all of that as well. And that kind of plays into the social pressures. So is compassion trainable? Turns out that it is. This is what the research is telling us. But I want to share with you the last few minutes here. A woman by the name of Joan Halifax. She's a Zen Buddhist teacher. She's an anthropologist and an ecologist. She's at the Upaya Institute in New Mexico. And she says, this is her model of an act of compassion. She says, compassion cannot be trained. It cannot be trained, but it can be primed. We can prime for compassion, and we can prime the components of compassion, or we can train, rather, the components of compassion, which then lead to a compassionate response. And she says the current definition, and I have a bias. I should have had a disclosure slide at the beginning. I have a compassion bias, and I have a Joan Halifax bias. So she says that the current definition of compassion, the ability to be aware and recognize suffering, and then the motivation to relieve it, is limiting, because compassion is an emergent process that arises from an interaction between living, changing organisms and within the context of the environment. So for those of you familiar with systems thinking, the therapeutic interaction is a complex, adaptable system. And then what emerges from that is this compassionate wisdom. So it's not, compassion isn't a competency per se. It's something larger in an emergent process. Does that make sense? Does it give you goosebumps? Like it gives me goosebumps. So here's her model. And you'll see that this model, though you'll see a lot of similarities in language, in concepts, to what Maxie talked about, to what Sharna talked about in her Titanic model. And I love that, and I think it's great. So it's another model, and I'm going to go through each one briefly, but I do want to give you some ideas of what this might look like practically for you. So the attentional domain. So this is being focused, being present. And within the context of the therapeutic interaction, however you want to do that, everyone has different techniques. Same, like with Max, I like using the breath. So that might be your anchor. Just, am I present? Am I present? Outside of the therapeutic interaction, you can cultivate attention. Lots of ways. Mindfulness, meditation, research. I mean, we've got enough to show us now that we know certain practices can help increase our attention and our focus. So you don't have to necessarily do yoga, but there's these contemplative practices, mind-body practices that might help. And then the affective domain. So this is the idea that we need to cultivate being aware of our own emotions, so then we're able to regulate, therefore able to co-regulate. So if we can regulate our emotions, we do have research showing that can help create more clarity and increased discernment. And it also can help us be more aware of other people's emotions, and then that gives us a higher chance of responding more appropriately and more compassionately, and meeting their needs, of course. And then one more point on this I thought was interesting. So this, I'm just talking about being aware and regulating emotions, but we can also actually cultivate positive emotions, which that was the loving kindness meditation, one way to do it. So by cultivating these feelings of warmth and caring, that can actually activate certain areas of the brain that also help with our discernment skills, our perspective-taking skills, and decision-making. And then the intentional domain. So a lot of people who do practice intention setting can attest to the power of intention, and it can influence process and outcomes. It can influence our thoughts, our voice, our language, our body language, even the actions that we take. And it's this intention that distinguishes compassion from empathy. So empathy is a competency. It may or may not trigger compassion, but compassion is this emergent process that's more of a wisdom. So one thing that you can try this on Monday. you can set intentions. It doesn't have to be this, but you can just set an intention, and you don't have to, chant it or shout it out or anything, or have an altar or a ritual. It's just something that you say to yourself. So you can set it at the beginning, maybe when you're hand washing or something, and then you remember to revisit it throughout and see what that is like for you. And you can do this not just in the therapeutic interaction, but in your life too. Block intention setting for different phases of the day. So I like these. Be present. This is from our friend and colleague Matthew Taylor. Matthew Taylor, he's a physical therapist and yoga therapist, and he came up with these. I have something sort of similar that I do. I say, I am here to serve. I don't necessarily go through all of these every single time, but be present and care for myself first. Be present for the person in front of me, and I am here to serve. And then insight is really the idea that the cultivation of all of the above domains can lead to a clearer and deeper understanding of the person suffering in front of you. And that's what we need and we want for that connection and to provide a compassionate response. Embodiment. So this is really this felt sense of your experience of being in your body-mind within the environment. And the more in tune we are with our own physiological state, that the more chance that we'll be able to self-regulate and attune with the state of others. And within the therapeutic interaction here, again, it's just having that felt sense. Maybe you want to anchor with the breath, or maybe it's just feeling your feet on the ground. And this can be challenging because if you think about it, what I'm asking you to do is be fully present and aware with the person and listen 100%, yet still be aware of your own physiological state. So this is a skill that you can develop. It's like you're dividing your attention. So now you're not going to be doing a full body scan while you're listening to the person, like in depth, but there's this sense of, can you, even now as you're listening to me, can you keep that sense of presence? Can you feel your breath, your feet, and be fully attentive? And you can practice that, of course, outside the therapeutic interaction with different contemplative practices. And then the final domain is the engaged domain. So this is really compassion in action, the skillful use of all of the above domains, and it is an emergence of a compassionate response that will be ethical, it'll be value-based, it'll be practical, and it will be based on the partnership between the healthcare provider and the person. And it's important to note here, your compassionate response might be offering advice, recommendations, helping them with their goals or their daily planning, but it also could be inquiring or active listening, and it could be doing nothing. So we have to stop getting our heads around the idea that compassion is being kind or doing this or doing something to someone. It's, it can come in all shapes and sizes, and it's this wisdom that emerges from priming these. Does that make sense to you? So doing nothing and allowing space and time for the person to have their experience, and respecting the individual's capacity to experience their own pain or their own experience. From a neurobiological perspective, if we rush to fix someone, and we're well-intentioned, that's our profession, that's what we're hired for, that's what people want us to help them. But if we rush to fix without validating the pain experience, that might trigger the person's physiological defense mechanisms. And that could be withdrawal of those vagal influences, increase that sympathetic nervous system dominant, and then that will negatively influence their pain. So here we are well-intentioned, and we think we're being compassionate because of that linear, reductionistic, be kind approach without this larger wisdom, and we could be doing the person more harm. So important to keep that in mind. And these questions are from Joan, and I love these 3 questions. I hope you are inspired by them as well. So these questions you can keep in your mind when you're working with people. How can I best serve? What can I learn? And what does this person need to succeed? And the what can I learn part is that sense of therapeutic humility, and that term that Joan uses, if some of you may have heard the term therapeutic humility, that we are we're not attached to these outcomes. So at the end of the session, at the end of the therapeutic interaction, maybe, again, hand washing, and maybe we signify that our work is complete with an exhale, and we detach from the outcome. We do our best, it's a partnership, and then we're done. And then we can move on to the next interaction with a fresh perspective, with clarity, and for the whole compassionate process to emerge once again. And rainbows and unicorns and hearts and everyone's happy. So this is just a summary of the model and the map of compassion as an emergent process in a complex dynamical system. So attention, the affective, being aware of our emotions, regulating, the cognitive domain, so that's that idea of the intention and the insight, and then the somatic domain, so that is the embodiment and the engagement. And this gives rise to compassion, wisdom. So is it possible to have too much compassion? Well, I hope based on what you've just heard here that you would say no, because that would be like saying I have wisdom fatigue. Right? It would be like saying I have, the more wisdom that I cultivate, like the less I have. So it is this idea that the more resources we have and the more we prime for this process, we're just going to get better and better. And like I said, the research does corroborate with that. So in closing, compassionate pain care, a comprehensive, compassionate pain care plan, a little something I came up with that's based on everybody else's ideas, so this isn't original. There's no original idea, right? You read that TEDx talk or listened to that talk. But I created this based on, all these other ideas. So incorporating the 3 orientations of compassion for others, receiving compassion, and then self-compassion, giving and receiving self-compassion in the context of the person in pain and the healthcare provider. So that's what we talked about today. Okay? But it goes beyond that, obviously. We have to also look at friends and family. We have to look at the healthcare organization. So if the leaders and the organization, if their values are not in line with compassionate care, we're going to have an issue. And the community at large, which is like just everybody in the world, I think. So I think that, and there's a whole chapter in that Oxford Handbook of Compassion Science on compassion in healthcare and compassion in education. And so I think compassion literacy is something, if I'm blessed to be on this earth for a little bit longer, I just think compassion literacy is something that I'd be interested in. So if anyone's a researcher or interested in that, talk to me, because it's okay. So just some resources: the Compassion Bridging Science, Bridging Practice and Science in the upper left-hand corner. That's a free ebook. Over 30 of the leading compassion researchers contribute to that. A lot of great info in there. I can just email me or talk to me. I can send that to you. The Oxford Handbook of Compassion Science, which I've referenced a lot. That one actually, I think earlier I said 30. That one's like over 60 compassion researchers. Paul Gilbert's book, Kristen Neff's book, and a shameless plug for our upcoming book, The Yoga and Science in Pain Care. Everything I talked about here and more, and practices and references are all cited in the Compassion in Pain Care chapter. So thank you. I'll take some questions. Thank you so much for your time and your attention and your, what I felt was compassion.
Can you speak a bit more about how empathy is different than compassion?
Yeah, thanks. Did you know that I wanted that question? Could you
Maybe.
see intention? See, it worked. No, I had a whole huge part of that on here, but we had to cut it out. So, okay, speak more to, okay, so empathy. Now, the definition of it, first it depends on how we define empathy. And that, from what I've read, is even more elusive, the definition of empathy. There's emotional empathy, cognitive empathy, social empathy, behavioral empathy. So when I look at empathy, and I actually even wrote this down because Jamie said, you better be prepared to tell me what empathy is. And now I can't find it, but it doesn't matter. I mean, I think I pretty much know what it. So empathy is really the shared experience of another, and emotional empathy is that idea that you can be in someone else's shoes and share that experience. So if we're looking at emotional empathy, it's a competency. So it is something that you're feeling, but it doesn't necessarily lead to compassion. So in a lot of the researchers, and now Tanya Singer, Olga Klimecki, they're empathy researchers kind of, well, I'm making that up. I was going to say empathy researchers turn compassion researchers, but that's not true. But they researched empathy, and what they found out with fMRI studies and other studies was that empathy was a totally different construct, and empathy is neither required nor sufficient for compassion. So you can be empathetic with someone, so you can share their emotions and feel it and connect, but that doesn't necessarily mean you're going to have this, hopefully, the compassionate wisdom. It's not going to necessarily lead to that. Now, empathy can be a motivating factor. It can be a trigger for compassion. I'm not bashing empathy. It can be, but not necessarily. And then on the flip side, what some of the research is saying is empathy may not be required. They're saying it's not required for compassion. And that just gives me goosebumps, because how many people, are told maybe that you're not empathetic, you have problems with empathy. Well, maybe we don't need to train empathy. Maybe we have this other process. But again, it depends on how you define empathy. So if you're defining empathy as an increased insight and understanding into one's suffering, well, that's one of the components of compassion. That's one of the primers. So I hope that helps a little bit. And I do want to say this, because I have the opportunity, since we're talking about it. The fMRI research that Singer and Klimecki did, they did it with an advanced, Matthew Ricard, an advanced Zen meditator, Buddhist meditator. And what they showed was that when he would do the empathy meditation, so he would share the experience, they showed him pictures of children suffering in videos, and then he had to just imagine, be with them in their suffering. The fMRI had areas in the brain with negative affect, and I think it was like anterior insula and anterior cingulate cortex. But it was areas of the brain, different areas of the brain than when he did the compassion meditation, like what we did, kind of that loving kindness, and then he was extending warmth and kindness. And the fMRI was activating the pro-social network, the social affiliation. And then he felt, as well as they did follow-up replicate studies, not fMRI, but with groups, and they coincided. And what they found was that in all cases, the empathy training group, they felt emotionally exhausted, more sensitive, so they did feel like they could pick up people's emotions, but even in everyday normal activities, and that was just emotionally exhausting. And that the compassion was opposite. They felt invigorated, they had a higher tendency to help others. And so some of what the researchers are saying here is that it's not empathy we need to train necessarily, it's the compassion we need to train. And then they've coined the term, instead of compassion fatigue, as empathic distress fatigue. If you're interested, email me. I have a lot more info, but look up Paul Bloom, Bloom. He's a clinical psychologist, professor at Yale, and he has an article in Boston Review that just came out. He's got actually a lot of stuff out for many years, but it's called Against Empathy, and it is quite thought-provoking, and it'll ruffle some feathers, and I've posted it, and I had some not very nice things said to me, but it's and then what's interesting is that it's so much of this is like it's language, because if you take, anytime you take the two groups, we're talking about the same constructs and the same things. It's just people are attached to the language. They've got their teddy bears and they're not in the van, they're in the car. So, right? Okay, so thank you.
All right, so we have time for one more question, but I see two questions. And one online. So Rajam's giving me the do one online. So we'll do that and then see where we are. Otherwise, Shelly's here. So the other questions, if you want.
And I'll try to answer this one faster.
Okay, Linda Crawford asked, do you use Neff's self-compassion test with clients, and has anyone yet used it as an outcome measure and correlate it with improved pain experience afterwards?
Okay, so thank you, Linda. So for the second part, yes, the self-compassion scale, that's the scale that's used in the studies that I quoted. So the studies that show increased compassion is related to in the context of people in pain. Neff's measure is used. Have I? Yes, I have, but I use it a little bit differently. So I don't always bring it out, right away. I don't have any system as to who I use it with or not. It's usually after quite a bit of time with people, and it's usually sort of organically comes up this idea that they may be interested in learning more about compassion or self-compassion, and kind of, I guess, a little bit of motivational interviewing, like if they feel that they could use a little more self-compassion, if they think that's lacking. And as I think most of you can appreciate it, this is just sort of an organic, sort of natural thing that happens. And then what I'll do is because it's online, you can find it online, and then I'll give them the link, and then they do it on their own, and they don't, some people have come back to me and expressed, the results and that, but it's really for them, and then it just opens their eyes, and then we might have a little discussion, and as of now, I'm not really looking at the score and analyzing, it's just a conversation starter, and it confirms that, oh my goodness, I have, low compassion, and so it goes from there, it builds, and then we might do a self-compassion practice, which is, there's a lot of different self-compassion practices that obviously we can't get into now, but so I hope that answered your question, Linda. Thanks.
Thank you, Shelly, for a great talk. So we're going to have our final break of the day. So, yep, let's give a round of applause. Thank you, so we will get started right at 5:15 with our last speaker. So take a little break, have a wiggle, and then we will see you back here soon.